what I would tell you is learn how to say no. It's as simple as that. No is the most powerful word in the English language. It does not need an explanation, it does not need a defense. When you learn how to say no, you avoid doing what I did, getting overscheduled and running late everywhere that you go. As simple as that. You say no, you get more sleep. You say no, you get more time for yourself. You say no, you save money for vacations and lovely bags and beautiful jewelry. So my advice to you is learn how to say no. So traditional mammography is actually plain film mammography, and we have moved well beyond that to what we call digital mammography, which uses the assistance of computers to manipulate the density within the breast to make diagnostics easier. A 3D mammogram is what we call tomosynthesis. It's where they take multiple views through the breast, multiple cuts through a moving mammogram. So it's pretty much the same as a traditional mammogram, or what we would consider a traditional mammogram now, which is a digital mammogram. In women who have dense breast, who are perimenopausal or premenopausal, a 3D mammogram is superior to a plain mammogram. It increases the detection rate of breast cancers in those populations by 38%. It is optional, and some insurance plans prefer not to pay for it, okay? If you have fatty breasts or breasts that are very easy to see through, then a 3D mammogram isn't really going to benefit you much. So you don't need to feel as though you need to cough up extra dough. But Medicare does pay for 3D mammography. Most insurance plans will pay for 3D mammography for diagnostic purposes, which means you're going there with a problem that is being evaluated. Most importantly, however, is get the mammogram. I'll take it. Get a 2D, get a 3D, get a mammogram. Because no mammogram is no diagnosis. Every year, period, from age 40 on, period. Not every other year. Not starting at 50, 55, 60, 65, 70, 75, 80, 85, 99, 95, okay? And those recommendations I'll slap up there in a little while as well. If you have elevated breast cancer risk, if you have a family history where members of your family were diagnosed with breast cancers at early ages, before the age of 40, then you may need to start mammograms before the age of 40, and it should be discussed with your provider. Every year, 40 on, as long as you have quality of life and feel as though you would benefit from it. So I do not give patients a cutoff point for mammograms, as long as they have quality of life. I think the most important thing is to understand that cancer treatment is individualized. There's no cookie cutter approach. And the treatment plan that's developed for any given patient has to be specific not only to their disease in the breast, but also their overall health, their age, their willingness to undergo what other additional treatments are recommended in addition to surgery, and what their goals are for treatment. And it should be a shared decision. The days where we just tell you what we're going to do and you smile and grin and bear it, that's pretty much over. It has to be a discussion and a shared decision, because in addition to curing the disease or controlling the disease or eradicating the disease, we want you to be able to put that behind you so you can go on and live a quality life. And understanding your goals is half the battle. Different people want different things. Different people have different expectations, and they have to be managed accordingly. Sometimes expectations are out of line with reality. And those are difficult discussions to have. So, the approach now is as wide and broad as you can possibly imagine, from complete eradication of the breast, and in some cases to no surgery at all, and managing it differently in the appropriate patient. So there's no one size fits all anymore. It has to be shaped and designed for you. And there has to be an understanding of what is a reasonable expectation for the end of treatment. If we don't provide reasonable expectations, nobody's happy. We're not happy, you're not happy, your families aren't happy, you know. But I think if we have open and honest conversations about what is a reasonable expectation and what are your goals and how can we get you there, I think we get the best results all around. And there'll be a different result for every person. So the first question is, how often do we see patients that may come with family members, loved ones, or friends who may have a different expectation and a different goal than they do? Every day. Every day. And the most important part of the discussion when that occurs is for the patient to understand that they are an autonomous individual, and we will respect their choices. Your body, your choice. Okay? Sounds familiar, doesn't it? It definitely applies. My job is not to make the family member happy with the decision of treatment. It's to make the patient happy with the decision for treatment if they are an autonomous individual. If they are not autonomous, that's different. That means that person is their healthcare proxy. And sometimes they make great choices, and sometimes they make not so great choices. But it's really having honest discussions about it. And the same thing I told you. Now, if somebody's sitting with me and their family member is giving them the blues, I look over and say, shh, 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 shh. Okay. And I did a case today. I'll give you a perfect example. The patient was very torn about what she wanted. She had loving friends who were very loving, encouraging her to have a surgery she really did not want to have. She had her mother on the flip side of that coin encouraging her the exact opposite of what her friends were encouraging her. And she was incredibly torn. And the bottom line we talked about is, what are you most comfortable with? Let's take all the noise out of the room. What is going to make you get your peace of mind back? Where are you going to find your sense of peace with this thing that has happened that you had no control over? And it is important to be able to understand your wishes. It is important. That's why I have Kathy and I have Markeisha and I have a staff to help do that hand-holding, because after you talk to me for 2 hours, what else you want me to say? Sometimes you need to talk to them a little bit. But it's having somebody to support you in your choices and respect your decisions. And I don't always agree with your decisions, but they're your decisions. And that I can respect and that I can follow along with. This is a different perspective. There's some importance to siloed care. Specialists specialize in what they do. Medicine has become so complex, and it's evolving every day, that we can't keep up with everything across every specialty. So even though it can be painful to have to see more than one doctor, and that we can't go just to our primary care doctor anymore and they cover everything, like the world of our old general practitioners, and not old, our previous general practitioners and previous general surgeons, there is some benefit to having care in the hands of someone when that's all that they do. What the data shows is when you see specialists for special issues, you have better outcomes. You have access to clinical trials and cutting-edge treatments and therapies that you can't expect your family practitioner or your internal medicine doctor to keep up with. I have to keep up with the breast recommendations, which have changed every year. I couldn't imagine trying to keep up with the GYN recommendations, the GI recommendations for colonoscopy, what's good with joint health. I didn't even know anything about this stem cell stuff, so I've learned something today. Never heard of a Kegel ball, because that one was a big hit, and ain't nobody peeing in no pool. So that is not going to happen. But the reason why we have siloed care to a degree is so that you have access to people who are following their calling, because we are following our calling with passion, with love, with integrity, and with a desire to learn more, do more, give more to these patients. It provides you greater access. So the kind of icing on that cake is when we get to work in multidisciplinary settings, and when we get to sit down together, and we get to have opportunities to look at each other's notes, that's the icing. But the cake, the meat, is that doctor has spent all their time honing that craft to give you the best that is out there right now. So that's the benefit of siloed care. So there's a twofold answer. One of the solutions to that, because that's complex across the country, not just here, is the concept of the patient navigator. Navigators who work with us, who are typically nurses or social workers, and they have different specialties to help patients navigate those things. So that's one aspect that can be helpful, and there are a lot of navigators in the system. We have one for breast, there are some for ortho, there may be some for oncology, but that is their job to help you navigate the system and to help put these pieces together. The flip side of that coin is be honest. Tell us who you see and why. Because if we don't know who you see and why, we can't send them the documentation so they know what we're doing. You know, the old adage that I tell my patients is, we know y'all lie. We know. You don't always tell us everything. People come see me for breast and they don't tell us everything because they think it's not related. Well, that has nothing to do with my breast, so I'm not going to say anything about those 6 people who had ovarian cancer and colon cancer in my family. So just be open and honest with the provider so that they have the opportunity to start putting those pieces together for you. If you say, you know what, I don't know if I had that test, well, it's a lot easier for us to go see if we can hunt it down than for you to figure it out. You know, and one of the things Dr. Wexler said I think is really important, and that Ms. Potts said that's important, is, oh, it's hard to ask these questions. It should never be hard to ask a question. If you're afraid to talk to your provider, get another provider. You should be able to have an open and honest conversation. And if you can't, that there's something that we're not providing or that might not be the right relationship for you. But there really should, because we're in medicine, you know, we may have little things we chuckle about in our brain, but the bottom line is that we're there to care for you. And if there are things about your health that you feel uncomfortable, that we're not going to be receptive to, you need another provider. Because we can't fix what we don't know. And we can't fix what we refuse to hear or refuse to see.
Thank you.